Hey everybody, it's a pleasure to be here to talk with you about HIV and long COVID. So as was mentioned, I'm an HIV clinician and researcher, but for the last 3 years, I've been trying to understand both the natural history and the underlying biology of long COVID through our UCSF-based program, which is called LINC, as well as the US National Recover program. Treated HIV is associated with an excess risk of multiple comorbid conditions, things like cardiovascular disease, blood clots, cognitive dysfunction. And these are quite similar to the conditions that we're seeing in a subset of people following SARS-CoV-2 infection. There's increased incidence of a variety of these conditions in the months to years following COVID-19. And some people also have unexplained symptoms not attributable to another diagnosis, which is called long COVID. But despite these parallels, we don't really talk about long HIV as a clinical entity. And I think that the reason for that is that we probably think about the two viruses quite differently. A lot of work has been done in trying to understand the mechanisms of HIV-associated chronic illness. It's thought that both acute and persistent HIV infection result in irreversible tissue damage, which can lead to chronic inflammation, hypercoagulability, vascular disease. And this can be further enhanced by things like autoreactivity, microbial translocation from the gut, and reactivation of latent human herpes viruses like EBV and CMV. These are the exact same mechanisms that have been proposed to contribute to long COVID, and there's compelling preliminary data for each of these mechanisms being at play in long COVID. So the parallels are really striking. In addition, it seems that HIV may be a risk factor for long COVID. We did the study about a year ago, a small case control study, in which we found that in our cohort, people living with HIV had 4 times the odds of meeting the case definition for long COVID compared to people who were HIV negative. In a follow-up study earlier this year, we found that this was really driven by 2 types of symptoms in people with HIV, neurocognitive symptoms and GI symptoms attributed to COVID-19, but not other symptoms that are common in long COVID like fatigue or cardiopulmonary symptoms. And there are ongoing efforts to explore this in much larger cohorts using electronic health records. And so this is a really important preprint from Grace McComsey's group showing that people living with HIV are more likely to have long COVID symptoms as well as incident medical diagnoses in the weeks to months following COVID in comparison to people who are HIV negative. Not all of the studies of this are positive. Not all of them show increased risk in people with HIV, but there are some important ongoing efforts funded by AMFAR and led by Annie Antar at Hopkins to address this specific question. But let's say this is true, that people with HIV are actually at higher risk of long COVID. Why might that be? This is from a recent review that we wrote. I don't have time to go through all of these different factors, but I'm going to highlight a few of them related to the virus itself, as well as chronic inflammation and the potential causes of that. So I think it's becoming clear that in long COVID, the virus matters. What you see here are data from Ziad Al-Ali's group at the VA that showed that among people who qualify for antiviral treatment during acute COVID-19, those who get treated have a lower risk of long COVID symptoms as well as incident medical diagnoses in the subsequent 6 months compared to people who do not get treated. So it seems that early treatment, at least in a subset of people, protects against long COVID. Why might that be? Well, data from our group was recently posted as a preprint. This was a study led by Dan Kelly and Scott Liu looking at early markers of long COVID. What we did in the study is for people who had acute SARS-CoV-2 infection, we did daily PCRs for 21 days. And we found that people who were destined months later to develop long COVID had a greater magnitude and longer duration of persistent viral shedding, an infectious virus, than people who were destined to fully recover from COVID. So this provides one potential mechanism by which the observation on the left could work. and suggests that the viral dynamics early on are very important. So just as early ART matters in HIV infection by minimizing the size of the reservoir, early COVID treatment appears to reduce long COVID risk, potentially by reducing the viral burden in the first few weeks. As an HIV doctor, people used to ask me at the beginning of the pandemic, what is the difference between HIV and SARS-CoV-2? And I would say that HIV is a virus that persists and SARS-CoV-2 does not. It comes and goes. I think there's been a lot over the last few years that have challenged that framework. Many of you will have seen this study recently published in Nature showing that SARS-CoV-2 genetic fragments could be identified for up to 6 months post-COVID in people dying from other causes. David Walt's group at Harvard has found that spike protein can be detected in blood from individuals with long COVID, a subset of individuals with long COVID, for up to 12 months post-infection, suggesting that there could be viral persistence. So there's a lot of work going on now to figure out what this means, but I think a key question is whether SARS-CoV-2 persistence is more common or more consequential in people with HIV infection. One of the first studies that we did in long COVID was looking at markers of inflammation that we were familiar with from studying HIV. And so in this study, we looked at people with long COVID in comparison to people who had fully recovered 4 months after COVID. And we found that long COVID was associated with elevations in some of these very familiar biomarkers like IL-6 and TNF-alpha. This held up in adjusted models and was maintained and even more pronounced when we looked at more specific phenotypes of long COVID, like cardiac or neurosymptoms. This has now been replicated in probably a dozen high-quality studies, and it bears a lot of questions about just as chronic inflammation drives pathology in HIV, does chronic SARS-CoV-2 associated inflammation drive pathology in long COVID? So that inflammation could be caused by SARS-CoV-2 persistence, but there are lots of other things that could cause it. And so Mohammed Abdelmohsen's group did this really nice study using samples from our cohort in which they identified that people with long COVID had elevated markers of microbial translocation. This is showing beta-D-glucan, which is a fungal cell wall marker. There were trends toward elevations in markers of bacterial translocation, as well as decreased tight junction integrity. And these markers directly correlated with some of the inflammatory markers that I mentioned previously, suggesting that this is one potential driver of inflammation in long COVID. Microbial translocation and dysbiosis are obviously common in HIV, and this also appears to be a hallmark of long COVID, and that sort of bears the question, could this be additive in people who are also living with HIV? So I'm going to shift now and talk a little bit about, beyond the clues to the biology of long COVID, what other lessons can we learn from HIV? And there are 3 lessons that I think are important. The first is the importance of biomarkers. So the validation of plasma HIV RNA as a biomarker in the mid-90s was totally transformative for HIV treatment. All of the clinical endpoints like CD4 reduction or progression to AIDS, which would take studies of thousands of people many years to see a benefit of treatment, went away because now the outcome of studies could be whether the viral load became suppressed. And that meant that there was a rapid acceleration of development of different antiretrovirals. This resulted in what we have now, which are dozens of regimens that are available and was completely transformative for the field. We do not have good biomarkers of long COVID like this, and those are really, really important to accelerate development toward therapeutics for people with long COVID. The second lesson is the importance of experimental medicine. So when I say experimental medicine, what I mean is using drugs kind of off the shelf, repurposing them, not to try to get something approved for treatment, but to probe the biology. We in HIV research are probably better than anyone else at doing that, and we've gained so many insights into the drivers of HIV disease by doing that. I think ultimately that paid off because Reprieve was built upon all of that knowledge that had been gained in these smaller probe studies over the preceding decade. And so we really, really need experimental medicine for long COVID, not just big studies of thousands of people with clinical outcomes to see if we can get people feeling better, but also smaller proof of concept studies to understand whether the biological pathways that we think are important are actually important. And so I hope to see more of those move into the field over the next year. And then the final lesson is the value of patient engagement. So we all know what incredible advocacy has come from people living with HIV in driving both the research and therapeutic agenda. That is completely mirrored now in long COVID, where people with the condition are setting the agenda, they are funding efforts, they are directly participating, leading research studies. It's amazing. But there is a major gap, and that gap is in connecting clinical programs to research programs. Clinical programs for long COVID right now are wholly inadequate. There are efforts to build them up, but they are not going to be at the scale that is necessary, and we really need investments like kind of the Ryan White programs that were so important for HIV in the early 90s to build up clinical infrastructure, connect people who are affected by the condition to research, and then have a mechanism for translating research findings when we make discoveries back into the clinics to the people who are directly affected by the condition. So in summary, people with HIV may be at higher risk of long COVID. There's a lot of overlap between the established biology of chronic HIV disease and the proposed mechanisms of long COVID. The HIV research model provides a path for studying long COVID and also for getting treatments into the field. We really need to convince our institutions, companies, funders to invest more in long COVID clinical and research infrastructure. And like HIV, I believe that long COVID is a generation-defining challenge that we must meet. So I will end there with some acknowledgements, and we'll look forward to the Q&A. Thanks.
Thank you, Michael. You've got a couple of minutes left because you did so amazingly in keeping to time. Has anyone got a question before we move on to the next presentation? It's fine if not, we can save them for the Q&A. But... No. Thank you very much, Michael.